Okay. It's a great honor for me to introduce Carmine Zoccali, and I will continue in Turkish. Carmine Zoccali, Türk Nefroloji Derneği'nin saygıdeğer dostlarından bir tanesidir. Bizi hiçbir zaman kırmadı ve Türk nefrolojisine hep desteğini maksimum düzeyde tutmaya çalıştı. Kendisi Türkiye, dünyada ve Avrupa'da en saygıdeğer nefrologlardan birisi olup Avrupa Nefroloji Derneği'nin dergisi olan Nefroloji Diyaliz Transplantasyon'un baş editörü ve gelecek dönemdeki de Avrupa Nefroloji Derneği'nin başkanı olacak. Kendisi bugün bize 2 tane konuşma tertipleyecek. Uçaklardaki bazı değişikliklerden dolayı buraya gelemedi. İlk konuşması endotel fonksiyon ve vitamin D'nin rolü kronik böbrek hastalarında. Kendisini konuşmaya davet ediyorum.
Aspetti che spostiamo ora le modifiche.
Mehmet, can I start?
Yes, Professor.
Ok, perché le stringo le cose? Ma le stringo io secondo me. La stringa. Hola.
You may start, Carmine.
Is it okay for you if I start?
Yes.
Yes. Okay. First of all, thank you for giving me the chance to speak without flying to Istanbul. It would have been my dream to join the meeting, but unfortunately I had serious problems with connection, and so I will speak from my desktop. The first of the 2 talks is about the impact of increased sympathetic activity in patients with CKD. Let me start from the figures of CKD worldwide. The proportion of the population of CKD ranges from 4 to 20%. And if you would like to strike an average, the average is probably 10%. Now, the causes of this epidemic, because it's a true epidemic, the high frequency in the population of this disease, are not immunologic disease, glomerular disease, or genetic disease, which are the traditional hunting field of nephrology. And I convince you immediately why the main cause are not this disease. Collectively, this disease have a very low prevalence at population level, 1 per 1,000 population or less, while the frequency of CKD is 100 per 1,000. 10% is tantamount of 100 to 1,000. So if you compare 1 to 100, it means that this disease collectively contribute to just 1% to the CKD as a systemic disease worldwide. The main disease underlying this epidemic is a silent disease, much common indeed, nephrosclerosis, a disease characterized by intimal hyperplasia and progressive renal shrinking over time. But let's trace the natural history of the GFR over time in renal disease. The GFR is initially normal, and then in some patients it evolves toward kidney failure over a variable time course. Now, once a renal disease is started, independently of the cause that the start at the same disease, specific factors enters into the scene. That is renin-angiotensin system activation, inflammation, and high sympathetic activity. And these factors interact each other in promoting the progression of disease. Today, as anticipated, I will focus on increased sympathetic activity. But let me remind you the microcirculatory changes that occur in renal disease. In proteinuric nephropathies, the main microcirculatory change is efferent vasoconstriction. This is maintained by angiotensin II via the sympathetic system, because the sympathetic system is substantially activated by angiotensin II. And this triggers glomerular hyperfiltration and proteinuria. But let's move to nephrosclerosis. Here, the microcirculatory problem is at afferent level, afferent vasoconstriction that generates glomerular ischemia. And here again, the main effect of afferent vasoconstriction is increased sympathetic activity. But if we move to the interstitium, to the renal interstitium, we can again see that both angiotensin II and increased sympathetic activity are at play, because both angiotensin II and norepinephrine, the main mediator of the sympathetic system, activate profound monocyte macrophage infiltration. Now, sympathetic activity may now be precisely measured by fixing a needle in the peroneal nerve. This is the typical phrasing of the sympathetic activity in a healthy subject. These are sympathetic bursts. In a patient with high sympathetic activity, these bursts are much more frequent. This is evident from the comparison control high sympathetic activity. The problem with measuring directly sympathetic activity is the fact that it gives you a precise idea on how blood pressure is controlled. When blood pressure goes down, sympathetic activity is increased, and these restore blood pressure. Vice versa, when blood pressure goes up in hypotension, there is sympathetic inhibition, and this tends to restore normal blood pressure. But see this in a graph. In the abscissa, you have mean arterial pressure, and in the ordinate, the number of sympathetic bursts. This is in the healthy subject. The blood pressure, the mean blood pressure is about 90 millimeters of mercury. Blood pressure 120 to 80. When blood pressure is lowered by nitroprusside to about 80 millimeters of mercury, you see there is a huge increase in the number of sympathetic bursts. And vice versa, when blood pressure is increased by infusing norepinephrine, the number of sympathetic bursts goes down almost to zero. Now, this technique, sympathetic neurography, is very precise indeed, but has limitation. The main limitation is the time, that it is time consuming, and it requires a dedicated technician. It's very costly. So we have a very reliable technique, highly reliable technique, but it cannot be applied in clinical practice, and even in large-scale clinical research. So in clinical research, more often than not, we rely on circulating biomarkers of sympathetic activity. That is norepinephrine, and the second biomarker, neuropeptide Y. Neuropeptide Y is less well known than norepinephrine. But this is a very important neuropeptide, a very important sympathetic neurotransmitter, and I will convince you about these statements later on in this presentation. Neuropeptide Y is strongly associated with inflammation. It influences central mechanism controlling satiety, and therefore it's also implicated in obesity. Now, let's me summarize the key point of this talk. I will start briefly with reporting sympathetic activity in stage 2-5 CKD patients. Then I will focus on sympathetic activity and CKD progression. And finally, we'll speak about the interference of sympathetic activity with CKD progression. I mean, the therapeutic potential which can be obtained by interfering with sympathetic activity. Let's start with the first point. The first study that focused on sympathetic activity in CKD patients was a study by Lichtenberg. This is a study of great historical importance. But as you can see, it was based on a very low number of patients, just 14. I think that today the New England Journal of Medicine would not have accepted this study for publication. And there were just 10 control subjects. But however, this study nicely demonstrated that sympathetic activity in patients with CKD is about 40% higher than in control subjects. But the difference which emerged from the head-to-head comparison of sympathetic burst in control and healthy subject of the previous slide doesn't tell you the whole story. This is again the graph that I showed initially, reporting the change in sympathetic burst when blood pressure goes from 105 to 80 millimeters of mercury. Let's put in the same graph the curve of patients with CKD. You can see the curve is shifted to the right. And if we compare healthy subject and CKD patient at the same level of blood pressure, which is correct comparison, the difference between CKD patient and healthy subject is very profound. The number of sympathetic bursts is 60 when the blood pressure is 105, and in healthy subject is just 5. So sympathetic activity in CKD patient as compared to healthy subject at similar blood pressure is 12 times higher, not 40% higher. So the increase in sympathetic activity in CKD is even more marked than it appears in face-to-face comparison with healthy subjects, as we did in the previous slide. What about biomarkers? I said that the most common biomarkers is norepinephrine. And as you may expect, also norepinephrine was markedly higher, more than double in CKD patients than in control subjects. But norepinephrine is a somewhat unreliable biomarker in CKD patients because it is profoundly retained in when the GFR is low. And this is so because the activity of renalase, that is the monooxidase that degrades norepinephrine, is substantially reduced in GFR, in CKD. Let's move to neuropeptide Y. Again, like norepinephrine, also neuropeptide Y is increased in CKD patients. So neuropeptide Y is at least a biomarker of sympathetic activity as acceptable as norepinephrine is. With these premises, we can move to the main focus of this talk, that is the relationship of sympathetic activity with CKD progression. In this graph, I plotted sympathetic activity burst per minute with urine protein and the GFR. And as you can see, there is an inverse relationship between sympathetic activity and the GFR. The lower the GFR, the higher sympathetic activity. And vice versa with proteinuria. The higher sympathetic activity, the higher proteinuria. So directly measured sympathetic activity is strongly associated with the main biomarkers that define renal dysfunction, the GFR, and renal damage, urinary protein. What about neuropeptide Y? As I anticipate, neuropeptide Y is an extremely interesting neuropeptide in patients with CKD because it mainly derives from the nerves in the intestine. And I know that yesterday morning you had a talk about the microbiome in CKD patients. So NPY is a sort of transducer of the effect of the microbiome on innate immunity and inflammation. And as I also anticipated, it's a strong appetite stimulant. And there are animal models showing that this neuropeptide is highly expressed in inflammatory tissue in the kidney, in inflamed kidney of experimental models like erythematosus in mice. And therefore, this peptide has the potential of altering the efferent arteriole, like as the norepinephrine, and also the potential to cause interstitial inflammation in the kidney. The two mechanisms I discussed at the start of this talk. Now, let me show the results of the studies we have done in a cohort of 756 stage 3-4 CKD patients. These are the cross-sectional analysis relating neuropeptide with systolic blood pressure and heart rate. And in this large population, blood pressure, systolic pressure was directly related in neuropeptide Y levels, while heart rate and heart rate are exactly the same behavior. And as you know, heart rate is another biomarker of sympathetic activity. And heart rate goes up when sympathetic activity is high. But let's move to the renal data. Cross-sectional analysis again, GFR and 24-hour proteinuria. You remember I have already associated sympathetic activity directly measured with GFR and with proteinuria. And the same is true with neuropeptide 1, inverse association with GFR as measured by serum cystatin C, and direct relationship with proteinuria. The higher neuropeptide Y, the higher proteinuria. Well, these are undoubtedly very exciting data, but these are cross-sectional analysis, and cross-sectional analysis are inherently weak. In order to make inferences about causation, we need longitudinal or follow-up analysis. And therefore, in the same cohort, we completed the follow-up study. And in this graph, I summarized the main results of this follow-up study. This arrow delineates the range of neuropeptide Y in CKD patients. Minimum value about 50, maximum value about 300. Across this range, there is a progressively increasing risk of CKD progression. And in patients who attain the highest level of neuropeptide Y, the risk of progression is 7 times higher than in those who have NPY at the lower limit of the normal range. An enormous risk increase across the whole range of NPY. And I would like to draw your attention that this risk increase was independent of classical and CKD peculiar risk factors, including baseline GFR, proteinuria, and serum albumin. And this risk was also independent of the type of renal disease. This was through glomerular disease and in nephrosclerosis as well. Now, this is data are on a single cohort. And as you know, editors of journals, when you present data in a single cohort, ask you confirmation in an external cohort. Otherwise, they don't accept your paper. And for this reason, we asked our colleague in Holland, Peter Blankstein, and the other investigator of the master plan study to redo the analysis we have done in our cohort in their Dutch cohort. And they fully confirmed our finding in the master plan cohort. So these data emphasizing the risk of CKD progression in CKD are confirmed in 2 cohorts, and the paper is under review with JUST. Let's move to the last point, interference with sympathetic activity, therapeutic potential. I'm back to the slide about Lichtenberg, showing that the number of bursts of the sympathetic activity is much higher in CKD. In these slides, I added ACE inhibitors because these authors measured in these patients sympathetic activity when they introduced ACE inhibitors. And as you can see, introducing ACE inhibitors almost normalize the number of bursts per minute. And therefore, the most commonly applied class of drugs applied in CKD patients as inhibitors are effective also because they normalize or almost normalize sympathetic activity. But the best way to explore the relevance of the sympathetic activity on progression CKD is to go to renal denervation. Here we have a small series of 15 patients with severe, moderate to severe CKD, very small series, just 15 patients, all of them with severe resistant hypertension. They were on treatment with 5 drugs on average. Their blood pressure, as you may imagine, before renal denervation was very high, 175/90. After renal denervation, blood pressure went down, and went down considerably, about 25 millimeters of mercury systolic blood pressure. But what matters to us here is proteinuria. Proteinuria in these 15 patients was on average 1.4 grams. After denervation, it was halved, 0.7. Due to the small number of patients, just 15, I remind you once again, just 15 was not significant, 0.24. But I am sure that you would agree with me that these data are much promising because they show the possibility of halving proteinuria in patients who are already on treatment with angiotensin-converting enzyme inhibitors and sartans. And it's important to say that in these patients, during the study, which lasted 6 months, remained exactly the same, did not get worse. Now, what about neuropeptide Y? Is there any potential for neuropeptide Y? I can tell you that neuropeptide Y is intensively investigated in oncology. It may retard tumor growth. It's drugs trying to mitigate the appetite in obesity are also intensively investigated. And there is a host of receptor ligands of neuropeptide Y that are being explored for their therapeutic potential in this, but also in other diseases. I believe that neuropeptide Y agonists and antagonists are truly worth investigating in renal disease. Let me summarize and conclude. When renal function declines, risk factors other than classical risk factors play an increasingly important role in CKD progression, particularly high sympathetic activity. I showed data demonstrating that sympathetic activity is about 10 times higher in CKD patients than in healthy control subjects. Directly measured sympathetic activity as estimated by biomarkers associate with GFR and proteinuria in CKD, and high NPY predicts high risk of CKD progression. And this last finding was confirmed in 2 cohorts. The class of drugs of highest efficacy for retarding proteinuric CKD as inhibitor potently inhibits sympathetic activity, and also sympathetic renal nerve ablation has potential for reducing proteinuria in patients with resistant hypertension. Finally, I showed you some interesting study hinting that interfering with NPY may have in the future therapeutic benefits. Thank you for your attention. So, the second speech is about endothelial function and vitamin D in CKD. I asked my friend Mehmet to better focus on the relationship with endothelial function and vitamin D. His initial proposal was for me speaking about endothelial function in general in CKD. But I think that the relationship with vitamin D is emerging as a much relevant area, and therefore I will focus exactly on this link. When the GFR goes down, when the CKD evolves toward kidney function, kidney failure, the kidney wall becomes smaller and smaller. And the opposite happens to the heart. In the most advanced stage, stages of CKD, the heart is large. And when the renal function is small, 125 vitamin D is produced in very small amount. And therefore, this factor is important in the pathogenesis of myocardial hypertrophy, because vitamin D receptors are highly expressed in myocardium. And therefore, 125 vitamin D may be a factor linking in CKD patients the risk of myocardiopathy to the severity of renal dysfunction. And we have two kinds of evidences for this link. The first derives from animal models, and second, in humans, derived from genetic epidemiology studies. Let's start briefly from basic science. This is a mice without vitamin D receptor, double knockout. And we compare this with a wild mice, intact vitamin D receptor. The effect on the heart of ablation of the vitamin D receptor is obvious. Compare this heart with this heart. The dimension of the heart in the mice without vitamin D receptors is about 50% higher than that of the mice. And this is basic science evidence of the importance of these receptors. Let's move to the genetic epidemiology. I focus on genetic epidemiology because genetic epidemiology can simulate clinical trials. And I will convince you immediately about this. The vitamin D receptor gene is in chromosome 12. And in this chromosome, there is a polymorphism, exactly a polymorphism with an allele, the B allele, that predisposed to mortality in dialysis patients. Patients having this B allele have a higher risk of death among dialysis patients. Now, as you know, chromosomes and genes are transmitted randomly at gamete formation, at mating. One gets the allele, the other doesn't get the allele. And this is a random process, and therefore we can use this polymorphism as a marker of the risk connected with the same polymorphism to left ventricular hypertrophy, because patients who receive this allele, risk allele, are expected to have a higher left ventricular mass. And we tested this possibility. Here, patients are classified as not having the B allele, having just one, and having two allele, BB. And the left ventricular mass index at cross-sectional analysis went along the number of risk allele, and it was the maximum in those who had two risk allele, intermediate in those who had just one, and minimum in those who had none of the risk alleles. These are cross-sectional data. And these cross-sectional data served as a hypothesis-generating data for doing a clinical trial looking at the effect of active vitamin D on the heart. And this is a trial that every one of you know very well. It's by Ravi Tadani, and it was published 5 years ago in German. Very famous trial. I was in the steering committee of this trial, and I have details of this trial. The primary endpoints was the change in left ventricular mass index by the most precise technique we have for measuring left ventricular mass, that is cardiovascular magnetic resonance. During the first meeting, when the steering committee designed the study, I proposed to adopt the left atrial volume as a co-primary endpoint, but the cardiologists were not convinced by my arguments, and therefore just one primary endpoint remained in this study. And this was unfortunate, because in Primo there was no change in left ventricular mass in the paracalcitonal group, and there was a small decline, of course not significant in the placebo group. So paracalcitonal left ventricular mass index as measured by nuclear magnetic resonance absolutely unmodified. This was a negative trial. But looked at the left atrial volume, which was measured in the same study but not included as a primary endpoint. This is the change in left atrial volume in the paracalciton group, a decline, while there was no change in the placebo group. And the difference was highly significant. And the change in left atrial volume was an important decline, -9%. Cardiologists know very well that a decline equal to 9% is clinically relevant. Now, how to interpret the reduction in left atrial volume in the Primo study? The hypotheses are two. The first, that the loading condition of the left atrium are reduced. That is, there is, for example, a diminution, a decline in circulating volume. And second, a change in compliance. Now, in Primo study, we could exclude changes in volume because body weight in the two groups remained exactly the same in both the control and in the paracalciton group. So the only remaining explanation is that paracalciton modified the increased ventricular compliance. But let's move briefly to the hard endpoint of the trial, which were secondary endpoints: cardiovascular hospitalization. The number of cardiovascular hospitalization during the 52 weeks of the trial were 11 in the placebo group, while there was just 1 in the paracalciton group. You see, with this small number, this may be a chance occurrence. For this reason, after the trial, we continued to collect hospitalization event up to the 110 week, after the end of the trial. And these are the results. The number of hospitalization remained unabated in the placebo group, but reduced substantially in the paracalciton group, also beyond the 52 weeks, and the p-value attained high statistical significance. But let's go back to the interpretation of the reduction in left atrial volume. I said that the reduction in left ventricular atrial volume pointed to an improvement in ventricular compliance. Now, the next question to confirm this increase in compliance is to look at the vascular compliance, because atrial compliance, ventricular compliance in general associate with vascular compliance. And to answer this question, that is the effect of paracalcitol on vascular compliance, we did a study which 2 years ago was published in hypotension. This study looked at flow-mediated vasodilatation. And the method of measuring flow-mediated vasodilatation was very well validated in a national study in Italy. I remind you the technique. You inflate the cuff of the sphygmomanometer. This determines nitric oxide accumulation and vasodilatation downstream to the occlusion. So when you release the cuff, there is a peak increase in flow. If there is endothelial dysfunction, the curve is flat. There is a lack of response to ischemia, that is defective nitric oxide generation in endothelial cells. A second test is the infusion without the cuff of the sphygmomanometer of nitrocrosate, nitroglycerin. Nitroglycerin causes a peak increase in flow, which is totally independent of the endothelium, because nitroglycerin is per se a nitric oxide donor and directly relaxes vascular smooth muscle cells. Now, let me briefly illustrate the protocol of these studies. Study we did with paracalcitol. The acronym of this study is PENNY. Screening phase baseline 12 weeks and 14 weeks. We measured independent and independent vasodilatation at the baseline, randomized patient to paracalcitol and placebo, repeated test of endothelial function at 12 weeks, then stopped treatment and repeated testing after 2 weeks. Let's see the main results. In the flow-mediated, endothelium-dependent vasodilatation was low both in placebo-treated and paracalcitol-allocated patients. This is the baseline. Before the trial, low values. During the first 12 weeks, flow-mediated vasodilatation went up a bit in paracalcitol-treated patients and went down a bit in placebo-treated. And after stopping this treatment, the flow-mediated vasodilatation reattained the normal levels. Please note that when analyzed in terms of individual responses in this inset, the changes in flow-mediated vasodilatation were even more statistically significant than that appeared from a simple parametric comparison, which was per se highly significant. The endothelium-independent response, that is the response to nitroglycerin in both groups, was exactly the same. So the effect of paracalcitol seems to be specific and limited to endothelium-dependent vasodilatation. As you know, a potential purported side effect of paracalcitol is that of lowering the GFR. And during the trial, we noted that the GFR went down a bit, about 6 milliliters per minute in the paracalciton group, but not in the placebo group. But this was clearly an hemodynamic effect, something that happens when you start an ACE inhibitor, because the GFR went immediately up after stopping paracalciton treatment, while it remained exactly the same in the placebo group. Now, the findings in this trial were certainly interesting, but we should be cautious in interpreting these findings, because flow-mediated vasodilatation is a surrogate, it's not a clinical endpoint. Therefore, we need at least confirmatory trials about the surrogate before embarking ourselves in new clinical trials based on clinical endpoints. After our study, 2 studies were published. The first by a Swedish group, Dr. Lundvall, that applied exactly the same protocol we applied in the PENNY study. The number of patients was less because there were just 24 patients in paracalciton and 12 patients on placebo. It's a study where the randomization was 2 to 1. Let's see the results. Similar values at baseline, but again, highly significant difference between the 2 study arms at 12 weeks. Again, flow-mediated vasodilatation went a bit down in the placebo group, and it went a bit high, a bit up in the paracalciton group, and the difference between groups was highly significant. This is the first trial, but there is another one that will be soon be published in JUST. This trial has been accepted for publication. While the previous 2 trials, the PENNY studies and the Swedish studies, were focused on patients independently of the vitamin D status. These trials focused in patients with vitamin D deficiency, that is 25 hydroxy vitamin D less than 20 nanograms per milliliter. Again, the protocol was similar to our study, except for the fact that duration of the study was 16 weeks instead of 12 weeks like in our study. And another major difference was the fact that the drug applied here is cholecalciferol instead of paracalciton, and cholecalciferol was administered immediately after the baseline study and at 8 weeks at the dose of 300,000 units. The main results is shown in this slide. In this study, the difference between the placebo-treated and the cholecalciferol-treated group was much more marked than we recorded in the PENNY study and Dr. Lundvall recorded in the Swedish study. The increase in flow-mediated vasodilatation by cholecalciferol, not paracalciferol, as said in the slide, was about 80%. 80%. It's an enormous increase in flow-mediated vasodilatation, suggesting that the condition of vitamin D deficiency amplificates a favorable response to vitamin D, at least for the response of endothelium-dependent vasodilatation. Now, it's true that now we have 3 studies based on a nice surrogate, like flow-mediated vasodilatation, that are highly positive. But you should not forget that this is a surrogate. And therefore, we need to confirm these findings in trials based on clinical endpoints. Now, you can object that we have a lot of trials based on clinical endpoints. We have meta-analysis as a matter of fact of trials testing the effect of vitamin D on cardiovascular events and cardiovascular mortality. 13 meta-analyses, each of these is a meta-analysis. And we have a meta-analysis of cardiovascular mortality, cardiovascular events, myocardial infarction, and stroke. But all these meta-analyses were negative. As you can see, the hazard rate, the pooled hazard rate, it's always near to 1. And the 95% confidence interval always crosses the line corresponding to 1. That is treatment, no treatment effect. So we have a lot of meta-analysis of studies showing that vitamin D, mainly non-active forms of vitamin D, do not produce a beneficial effect in terms of cardiovascular disease and cardiovascular complication. The problem is that these studies had not as a major focus patients with heart disease. Most of these trials looked at the general benefit of vitamin D to muscle strength and bone health. And cardiovascular mortality data and cardiovascular complication data were collected secondarily, not primarily. But the story is not ended because there are 7 trials looking at the effect of vitamin D on cardiovascular outcomes that are either ongoing or just now concluded. And some of these are included a very large number of individuals, more than 25,000. And there is another one of the same dimension, one in the USA and the other in Australia. And these studies have been either concluded last year or will be concluded in a couple of years, like the D-Health study, the Australian study in the old people. So we will again have fresh new data about the interference of vitamin D with cardiovascular health, and we will soon have, perhaps as a result of secondary analysis of this trial, the question we are longing for, that is, does vitamin D allow in individuals with deficiency of this vitamin, allow an improvement in cardiovascular outcomes? Thank you for your attention.